give it off to Nick King.
Thanks, Zane. And once again, thank you everyone for coming along today. So I wanted to spend a little bit of time talking about, the AI advances we're seeing and some of the impact we've seen so far on robotic surgery and just where that might take us in the near to medium future. Just to caveat, I'm not a doctor, I'm not a surgeon, I shouldn't be allowed anywhere near a scalpel. However, I am a math nerd and have spent a bit of time with folks like Zane and others trying to learn from you all and understand how we can take the data techniques that we've understood and apply them into robotic surgery. I think the amazing thing that's happening here is we're seeing just this huge amount of precision healing at surgeons' fingertips. And this is actually from a surgery I was fortunate enough to observe here. And you can see a lot going on here. And you've got the electrophysiology happening on the left-hand side. I'm not a surgeon, that looks like a left atrial appendage clip, I think, Dr. Kelpie, if I'm not mistaken. But there's a lot going on here and just shows how much information is actually available to a surgeon in this room, but also how do we think about capturing all of that? A video is one modality of capturing this information, but how do we take this data and process it throughout the surgery? How do we handle it post-surgery? And there's a lot of things that are happening in this space that I think just having the chance to observe this gave us a huge amount of depth into how could we combine this with robotic surgery and even provide feedback throughout the process to really help surgeons have that precision throughout the entire process. So just to introduce a little bit, robotic surgery has grown significantly in the last 5 years, but we still have a way to go. This picture, all my cardiac surgeons on the call be wondering what are all these extra things sticking out of this heart, and has it had some turbochargers placed on the side of it? We know that AI still has a long way to go. But with practitioners in the middle, at the center of this, and being able to develop protocols and understand what's happening, we're able to see a number of things happen. One is we can continue this path of rapid adoption and integration. And that's not just looking at how that robotic asset can support surgery and provide much faster recovery times and all the upsides for doing minimally invasive surgery, but also how do we think about the AI outcomes in decision making? Is it possible to map a surgery and provide almost like guidelines to a surgeon as to, okay, here is an optimal path. Here are things that you could be aware of. Is there telemetry data? Not unlike what Dr. Guy was talking about, are there ways to deploy this remotely, and what might that look like? And so you can take the expertise of many and provide them to a broader audience as well. I think the other piece here that's really exciting is the human brains are fascinating when it comes to processing information and how those neurochemical systems work. However, there is so much information, so much research coming out. Just since I've plugged into the matrix of cardiothoracic surgery, there must be at least a dozen papers worth reading a week just in some of these AI topics. And so how do you capture that information, understand where the trends are, and relate that back to the procedure that's happening right there and then? And that has two factors. One is, as a surgeon, you're able to get access to that information, understand the protocols as they're emerging, look at those as you prepare for that surgery. But also, as practitioners, you're able to continue to evolve those protocols and potentially use that information over time. And I think that is a huge opportunity. Is just how do you map protocol development, understanding with data you have, go back and look at historical surgeries and use those as really highly featurized data sets to validate those protocols as well. And then finally, I think there's some amazing visualization techniques here that could be very, very powerful, not just in how to work throughout the surgery, but just even the visualization of those procedures. We're able to render things much faster now. We're able to do this with greater precision. And I think that will provide more tools to practitioners to make these decisions in timely fashions, and have the option to focus and have a very minimal environment where it's high focus, and then have a much broader sort of score dashboard guidance that you could also be tapping into. So I think there's a couple opportunities here. This looks like a Da Vinci, Dr. Kelpie, I think it is. I don't want to offend anybody by getting the wrong machine, but he's nodding, so I'm doing okay on my test today. So we talked a little bit about real-time AI guidance during procedures, and I think the ability for AI to analyze imaging, providing surgeons with that guidance, looking for certain things, particularly with robotic surgery, there's a constant decision making that's happening. Looking for scarring, understanding how to position different assets, understanding, what was this route? Is this, if we take like an ablation, what is the coverage? Could you start to overlay and mesh over that heart and say, okay, here's where that coverage is. And so you can begin to look at real-time feedback as to where those procedures are taking place, but also look at the placement and manipulation, and almost looking at like how can you be more efficient with this. The other piece here is predictive analytics for post-operative care. And I think that's not just looking at the surgery itself. It could be looking at vital signs. It could be looking at ECG activity. It could be looking at a number of factors. And I think particularly as we look at what can happen post-operative, what does that treatment plan look like? Are there ways of understanding different things that may occur and be prepared for those? And being able to transfer that information very quickly to attendings and others participating in that patient's care. And I think one of the elements that we're consistently looking at is post-operative AFib. I think when we look at surgical risks for a lot of cardiothoracic surgeons, and particularly when we look at AFib, I think it's about a 30%, 20-30% chance, Dr. Kelpie, that there's a post-operative AFib event. And so understanding like what caused that, what were elements that may have contributed to that, and being able to go back over time and look at trends and validate them. And I think reducing that AFib risk can have a significant impact on heart surgery and how surgeries are performed. So let's get a little nerdy for a second. There, as you sort of saw in that image before, there's a lot of data streams going on. So looking at not just imaging, but also patient records. I think quite often as you go through and prepare, you've read the patient's records, their history, but sometimes you want to go back and check something, right? You want to go back and understand. You want to look at those real-time sensors and set thresholds, and maybe have recommended thresholds provided so you can kind of cover, vast numbers of metrics versus just the core, and you can even stagger those for tier 1, tier 2, tier 3. And so that would give you in some ways, a heuristic model to apply that data over time. And you could begin to apply that even before so you've sort of got to preoperative. So even during clinic, you could start looking at some of those historical elements and making some of those decisions much sooner on based on your own experiences. And I think this allows an opportunity for much more personalized healthcare, but also your data set of those things you've understood, those trends, you can quickly go back and validate. Now, I've tried not to use too many nerdy terms, but there is one here I want to introduce, which we call featureization. I'm not sure if it's actually an English word, but we use it in data science quite a lot. What we talk about with featureization is there may be some characteristic you want to note, right? It could be, hey, here's the complexity of this surgery. How do we go and define complexity? And I think we look at complexity as like, I think many surgeons can detail what a complex case is, but that takes experience and time. And so being able to, grade a case in complexity, but then go back and look at the factors for complexity, that only gives a benchmark that, you can apply surgery to surgery, but it can also enable, earlier surgeons in their career to be much more aware of those complexity factors. And so that allows us to extract these data sets, but also go back over time and refeatureize existing data. And that's a huge opportunity. Let's say there's a new study that tells us something could be very powerful. You could take that study and apply it to your previous surgeries and see if any of those surgeries would have been flagged with that new approach, and validate that protocol yourself, and then look at how that can be applied. And finally, this adds into an element of precision and procedures. So we talked about navigation here, but I think also, having the ability to make those real-time adjustments, getting feedback of, hey, like we're seeing, there's some factors here that might say, hey, put a atrial appendage clip on. And then finally, being able to do retrospective analysis. So let's say you go back and want to understand the surgery. You're talking to the patient, or maybe the attending is calling up and saying, hey, this is what we're seeing. The opportunity to go back and say, let me just check something. I want to make sure this isn't the case. And that gives you peace of mind, but also means that, you can make those confident diagnostic loops with the information at hand. So let's talk about data-driven protocol optimization. I think when we're looking at protocols and just the work that goes into those, having personalized protocols based on patient-specific factors is very key. We spend a lot of time looking at things like STS scores. We look at how these different scores are created. And, the STS data itself is about 700 features. Most of the STS score is about 45 features today. So there's a huge amount of data that exists in that STS model. And the reason for so many features and a very focused cohort that's used is that STS model has to be broadly applied across a population. But as you start looking at more of the factors for a patient, you can also start to look at, okay, are there other elements of these patient data that could be very beneficial? And so you can begin to identify those protocols and apply them for that patient and those specific criteria. And that gives you a continuous quality improvement where you're able to look at trends over time, make decisions, potentially even publish those insights, get those peer reviewed, and really contribute broadly with very accurate data. And I think that will reduce the time that it takes to do that research, but also validate that research and publish it. The other element here, I think, is like we're seeing a lot more of this as this data gets more prevalent, is the ability to create performance metrics and looking at how you benchmark against peer data. And I think this is a really interesting element, particularly as you're training new surgeons, as you're looking at creating objective assessments and understanding new techniques. This is a great way of sharing what you've learned, getting feedback, continually driving that process and improving, all of the community with those insights. So where is this all going? I think we're seeing a huge amount of surgical precision and efficiency that's available. And, I just want to reiterate, for me, and I also lived in Mountain View and spent a lot of time up and down the peninsula driving in incredibly slow traffic. But despite the traffic, there was a lot of technology that moved very fast. But I left that experience with something that was very critical, which is us as nerds, people like myself, we are nothing without experts like yourselves to sort of guide us as to where the impact can be. The beauty with math is we can apply it to everything. But if everything gets applied, then we're kind of missing the scope of how to put you at the center of this approach. And I think with these types of technologies, being able to move to that level of insight from experts like yourselves and shifting those into these, semi-autonomous execution steps, looking at this real-time decision support, really steps up how we're thinking about, the ability to provide this information. And on the other side of that, I think this democratizing expertise, making it available to surgeons globally, will shift the patient care for so many people and have a huge impact. And, even when I speak to experts, they're still learning. They're always learning. I've spoken to surgeons that have been operating for 40, 45 years. They're still so curious about this whole space and still learning. And I think that's admirable. And I think being able to share that will increase access to cardiac care globally, not just in the United States, but all around the world. And I think that's an amazing thing just to see the diversity in this group alone, is just how global you all are. So Dr. Kalpi, I'll pause there and see if you have any questions for me along that piece. And also let me know if I failed any of my medical questions on this short little spiel.
I'm very disappointed. So Nick, that was really, really cool. Not a shallow dive into what you do as a data scientist, but when you first of all, very nice talk, and brought it. Thanks for interfacing in a very complex topic. And not only are we cardiac surgeons, we're doing robotic cardiac surgery. So can you explain? I have 2 or 3 questions. So can you explain the process of training an AI model for use in robotic cardiac surgery, and what type of data are most critical for developing effective AI algorithms in robotic cardiac surgery?
Yeah, I think just to as we look at where those models sit, I would classify those that are outside the classification of software as a medical device and those that are inside the classification. So on the left-hand side, not software as a medical device currently, would be more informatics. So think of those as information systems that are providing support. I do think that definition will change in the coming years with FDA guidelines, which I think is a good thing. But those are often trying to unify all the data that's existing. So how to bring forward things from clinical notes, how to bring forward different readings and provide, are these categorized a certain way? And that training tends to be very specific. You want it to be, taking a broad set of data, pulling out certain features from that data, and then providing it a sort of a representation of that data in a way that can be easily digested. We see that a lot with things like, if we look for certain risk factors ahead of a surgery, are they, what's their CHA2DS score? Are they in a potential risk group that is worth always refreshing the team in the OR with. And so when you build those models, it's very much about, how do you provide the right information, the right insight to the team without overburdening them with so much information. On the right-hand side, software's medical device is very, very precise, making sure that, there are clear explanations of what's going on. It's like being a pilot. You want to make sure you know what the autopilot is doing so you can understand and respond accordingly, and be able as a surgeon to understand what is the entire theater, what's happening in that environment and what's going on there. And again, those are very deliberate models. So hallucinations are unacceptable. Being able to go back and validate that time after time, understand drift are also very, very critical on both sides, but even more essential on the mission critical side of that model training equation.
Yeah, no, those are great answers. I'm going to just ask you one more before we move on to Dr. Agami. How would you adopt a clinical AI governance structure in a hospital system? And, how important is it? And why do you think we need it? I mean, there's a lot of ethical talks about hallucination and should we trust it or not? What can you do to allow the trust? And, talk to me about clinical AI governance.
Yeah, you gave me a really short question there, Dr. Copy.
I'm so sorry.
No, I want to be respectful of everyone else, but I think here's the most important thing that I'd recommend to this group is that there's a lot of hype right now. At this point, everyone's telling us that AI could be Skynet, it's going to save everything, we won't need doctors. Let me tell you that there has to be a level of skepticism from us all, and that experts are still experts in the space. And when I talk about governance with hospital groups, with surgeons, it first comes down to how do you think about this as a practitioner? Forget AI for a second. Like, what are the gaps you're trying to solve for? Can you describe that problem very discreetly? And I think the other thing is there's a lot of technology companies that are pitching your organizations wanting to get in there, saying they're going to solve all these problems. I think you have to also be part of that discussion. Even lead that discussion is my encouragement, and look to those and drive it from a clinical or practitioner's perspective versus a broad technology adoption way, because that is where you can critique that and drive the right approach for understanding what can have impact, but also you can give feedback to teams and really help evolve that. Quite often what I see is that, an organization say, hey, we're going to adopt this technology that's going to solve all our problems. And it's great for the first 6 weeks. And then a lot of surgeons are like, hey, I'm not going to use that anymore because, it's not fitting with our flow. And a lot of technology companies don't think about that flow inside the OR, don't think about the flow inside a clinic. And I think you're all very busy. So, just even 5 more minutes after a clinic session is a lot. If you're doing 10, 12 sessions a day, that's a half an hour, it's 45 minutes. It's a massive impact. And so from a governance perspective, being able to sort of take the lead as experts yourselves, really thinking about what are the decision criteria, how do you validate that, how do you train on that, and how do you make sure it's solving problems and reducing complexity rather than introducing it. And that is really the beauty with these systems, is that if done right, they can be really, really huge in augmenting what you do today. But that's key. It's augmentation. It's not replacement. And then as over time, you can then compound that and have these compounding values and assets that can support greater sort of healthcare outcomes. So I think that space is one that I'm pretty excited about. See a lot of opportunity just in the way that people can, like yourselves, can engage and lead that conversation. And it's one that I don't know if Silicon Valley is capable of owning that conversation. They definitely can support it, but you still have to be a cardiac surgeon to be an expert on cardiac surgery. As much as I'd love to, have started 25 years ago, there's no chance. And so people like myself are here to support you.
Well, I think I'd like to change it and say augment us. So thank you, Nick.